Yeah. Okay.
Yes,
So,
sir.
all right, good. So I'll kick off. So that's our logo and our motto. Keep going. So for new people, if I tell you, you will forget, but if I make you do it, you will learn. So history and management. And on this one, there's not much confidential information, but it is to remain amongst us. Okay, so these are the Guru mantras. I've sort of back to front on the history station. You must consider. So in a child who's immunocompromised or potentially immunocompromised, always check for history of chickenpox. Make a note. Always ask the carer, how is the mother coping? How are you managing? Do you have any support? It could be the mother, it could be the patient themselves. If you get a teenager and how are they coping? It's a very useful opening question because, and after asking, you keep quiet, let them respond. School and family implications because the child is not on their own. How is the illness affecting the family, social life of the affected person and the family? Heads for teenagers and adolescents and the support available, living allowance and financial support. So these are the kind of key questions you need to note in your list that you should ask. Okay, so history in the clinical examination uh, has more than one. Can I put the request everybody to put their thing on mute, please? Because I think we're getting a background. Okay, yeah. So you get history in the development and management station, as we'll be discussing. You have to take it in the development, in video station, some history in communication, although it says you do not need to take medical history. And quite often in clinical, you may be asked or may be offered to ask some questions, like in MSK or possible neurology. So it's the same history, but putting it to the cricket analogy, you all have to have the same basic skills: batting, fielding, bowling, running, team player. But the way they play a 5-day test match, history and management station, is different to a 1-day 50 overs or a T20 20 overs, in which each has slightly different needs, and players have to adapt their performance to the format. And it's the same for the exam. And I have been going over how and what questions you should be asking in various stations. So history and management station and development station, although similar, there are differences. In the history and management station, the diagnosis is usually given or is obvious. It be a chronic condition: asthma, diabetes, epilepsy, celiac disease. You have, and there's usually a precipitating factor in the previous few months. What you need to know about is the current medications and the compliance, and then social support network to an extent you need to explore. Now, although I mentioned it's usually a chronic condition, sometimes you can get acute diseases in which you have to work out the diagnoses. In the development station, etiology of the condition is to identify. So they will not say this child has, I don't know, right-sided hemiplegia because of cerebral infarct or because of an operation. So that is something you need to identify yourself. Then you need to know what the child can do now how parents are coping with the situation, comorbidities and medications. That's very important, especially in development. Most children probably would have epilepsy or other complications, and you need to get that information. Social support network allowances, disability living allowance, mobility allowance, you should know about. So, questions that can be asked, which would guide you as to where you should spend more time. When were you first concerned of a problem? So that you'd ask the role player. And this gives you a time point to focus and elaborate in the history. If it was since birth, then you might need to explore antenatal more. If it happens at 3 years, then you need to explore what happened around that time. Another good thing to say, especially in the perinatal etiologies, what did the doctors tell you? So this gives you a synopsis of the illness and prognosis expected. You need not spend time getting details of a minimal value. So here, the example could be that the parents say, oh, the baby was born at 26 weeks. Then instead of going into how many days of ventilation did he need, did he have an IVH, did he get surfactant, did he have an MRI, did he get TPN, which are all important in themselves. But if you say, what were you told when he was discharged? If they say they told us to expect fits, delay, or they said he was fine, and we needed to come for follow-up, then you know what was it and what medications, etc. So that's important. And again, who's looking after the child in the MDT? So even on the history station, if the child is coming to the hospital for follow-ups, who's looking after the child? And if the child is outside in the community, who all are helping? So these questions can get you on the right track very quickly. Again, if you're absolutely lost, what do doctors do when they come and see them? So this was a story I was told to me by my registrar when I was a houseman, is that it was the case of long case, and he had a child about 4 or 5 who looked absolutely normal. He said, I went from head to toe, did everything, couldn't find anything. And then I asked, what do they do to you? So he says, oh, they keep feeling my head. And when he felt the head, he had a shunt, which obviously was not functional, not needed, but that gave him the clue. So they always look at my head, they look at my legs, they feel my tummy, and also what other doctors have told you. So this is not a cheating question. And if the role player doesn't want to tell you, they won't. But otherwise, they will say, oh, they said he had to take precautions or he had to eat or not eat certain things. So the analogy which I sometimes discuss is that, if you had a car having a problem 2 years ago and you were chatting to a friend now, oh, what happened to my car? So you don't give into great details of what the mechanic said or what he fixed. You give them, oh, it had some starting trouble and he changed the starting motor and it's fixed now. So keep it simple and brief.
Mommy, light चालू कर.
So your marks for history station come in information gathering and history taking, clinical reasoning, management planning, rapport and communication, and verbal and listening skills. So there are 4 marks virtually in this for your communication skills. And that is why I've emphasized so much on the communication aspect of your working. Most cases would be derived from the cases you would have seen already on the ward round. So if you probably think of what you saw on your ward rounds or in the clinic in the previous 6 months, I'm reasonably certain 90% of the cases or the topics would be covered. And although I showed you 4 marks for communication in this, remember, it is about gathering information. You should be leading with open and closed questions to move on and get the information and not get into a communication mode. Because if you get into a communication mode and start explaining, because that's what the role players would be primed to do, then you'd waste valuable time. So information from patients with chronic illnesses, asthma, Crohn's, diabetes, epilepsy, food allergies, and as I mentioned, crisis in the previous 3 to 6 months. So you need to keep that time frame in mind and try and explore that. The other thing you must do is read the information carefully. Whatever is given. I was just having a session with one of you recently, and there was a scenario put up. That was a communication scenario, and the candidate or the person forgot to read the top line, which gave the diagnosis. And then because that was not clear, the rest of the discussion didn't go as well as it could have. So read the information carefully, clarify and focus on the task. And this is what you can do. Most relevant and important issues while you're waiting outside for about 3.5 minutes. You will have a piece with some information, and then you need to just write down bullet points that you need to ask or things that come to your mind so that you do not forget. Now, the role player will ask you questions. Oh, so you must acknowledge the question. Is he going to get better? Is he going to have a problem? Is he going to normal school? Have you treated this before? If you ignore it, the role player will keep coming back to the same thing again till he or she gets a honest, reasonable answer. So you can park the query. Say, yes, I realize you're worried about this, but can I finish the history and examination? Then I will explain it to you. So park the query. That's very important to save time, but do acknowledge. History should be developmentally appropriate for age. And sometimes I've noticed some candidates don't do that very well. In a teenager, 15, 16-year-old who has come for diabetes, they ask, did you get all your jabs? Now, I know it's a question you need to ask, but if it's not relevant, you can ask, but they'll say, I don't remember, or I don't know. So infant, toddler, school age, and teenager, so you need to divide the history appropriately, though you can have screening questions for before, but was there any problem? May cover it. And then mentally go through the 2 to 3 minutes of consultation, consider differential, and like I say again, park the query. In teenagers, I think it's very important to ask heads. Now, the college is quite aware of the society or the place the exam takes place and the scenarios they put. Do keep the social customs in mind. But in India, Singapore, UK, I don't think it's a problem, but exams in Saudi may not have a question on, a teenager coming for the pill. So the heads is home life, education, activities, social, friends, sports, etc., drugs. Now, when we think of drugs, we only think of recreational drugs. But no, think of the prescribed medication they may have and their compliance. And when you're checking for compliance, A cursory, are you taking a medication, is likely to get you nowhere. Because nobody says, no, I'm not taking my medication. They'll all kind of wriggle in their seat and say, yeah, maybe I forget. So you need to be a bit more persistent to check that. And then sex, if appropriate in social context and you feel comfortable. Suicide and depression, because I think in one of the scenarios we discussed, it was a diabetic and she was feeling tired. Now, depression does make people feel very tired. So keep that in mind. Now, I'm not meaning to be prescriptive, but opening questions that I used to use when I was in the clinic is, thank you for coming. I'm Dr. Anil Garg. And then you can paraphrase the information you have been given. So the outside, you have the piece of paper, GP's letter or whatever, and say, well, I understand you have had diabetes for 5 years, but you're concerned about weight loss. Can you tell me more about it? Or your reason for coming today is, again, paraphrase, and what can I do for you today, or how can I help? And after that, you need to be quiet. Stay quiet and let them keep on talking till you think they have stopped. And yes, you have to provide your communication skills of, yeah, yes, go on, tell me more. And keep noting down the points they are mentioning. Be open and receptive. Eye contact is essential. And in our Asian culture, we have been brought up with that we shouldn't look to our elders in the eye, and that happens for everyone. So if you feel uncomfortable, look at the person's shoulder, left or right, and then from 2 feet or 3 feet, the examiner can't tell whether you're looking at them or not. Because in UK, if you don't look into somebody's eyes and you talk, they think you're being shifty and you do not know. React to their verbal and non-verbal cues. So if they say something or they bring it up, don't just ignore it. That may be a very important cue as to what it might mean, and you need to follow. So, following your initial interview, you should have enough information to change the passport portrait of the individual to a family. Because remember, the child lives in a family and illness affects everybody else also. Management decisions need to consider the whole family, although do expect and remember that the child is your primary responsibility. So, ideas, concerns, and expectations. So, what are you expecting? So, once you've had their point, then you can pursue them further. Social, psychological aspects of the problem and explore it at the right time. And there's no fixed time I can give you as to when you should be asking these questions, but make a note and you know that you have to ask them at 9 minutes when you get the 4 minutes left. Then you can have a very brief summary and then move on to the questions you have not asked or any other points the role player might say. Ask patients' expectations. So that could be quite early on. So yes, you have said all that. You have these 10 things. And so what would you like us to do today? Or what are you expecting to get from today? And their ideas may be completely different to what you think they want to know. Discuss and reach a management plan. And I personally believe, and I would say, be a positive doctor. Be reassuring, and remember there's a solution and help available for virtually everything. Irrespective of all your illness, there's always help available And even in death, there is the silver lining of organ donation. So just highlighting your communication skills, introduce yourself, clarify with the role player, interact with the child. If they say is there, just say, hi, how are you? Though I think in history stations, you will not have children at present. Be polite, good eye contact, and be at ease with parents and the child. Clear questions, start with open and allow the parents to speak. Child was unlikely to be there. Then social, family, emotional history and impact. And then again, after summarizing and you have finished everything, it will be quite useful to ask, is there anything that you feel is relevant I have not asked? Now, some people will come around and give you the answer. Sometimes they may not, but it's a good point to fill in. And remember, if you finish before time, you have missed something. So summarize for parents, give accurate information. In your own mind, have your differential, and you do not need to be discussing this with the role player or the parent. Just park the queries. Safe and ethical, relating to previous concerns, and safety netting is very important. I will see you again. You can be seen by the GP. A lot of people are very on with giving leaflets. Now, again, leaflets are a good thing to give, but depends on the situation. And then they should also be again followed up with a appointment or talk to a face-to-face person. Don't just say, well, here's a leaflet and goodbye. So, incomplete introductions, inadequate aims, poor eye contact, perceived not to be listening, cannot engage the parents, and does not engage with the child, which may not be that relevant here, but in your clinical station, then you would do not as well. This is again, you should have a good idea of the basic management of the condition you have. So spend a minute or two during a history time to write down the points that you would want to discuss with the examiner. Avoid medical jargons and poor management plan that does not relate to the parents or child's concerns. Last point is very important. You do not practice in isolation. At least I didn't. You have other specialists. You have other health specialists, health professionals, physiotherapists, dietitians, occupational therapists, specialist nurses. So use them. So don't try and say, oh, I'll treat everything myself. If you have to advise about a diet, refer to a dietitian. If you have to get more information on some specialist neurology, refer to a neurologist. But always speak to your own consultant first. So this is the last slide again. Chickenpox, how are you coping? School and family, illness and social life being affected, and always ask for the allowances. And although it's not that important in history and management, but do know of the education and healthcare plan. So if the child has got any chronic illness, that how are they getting their education supported? Listen to what is said, summarize back, and do not ask to repeat. Because if some information is given or they have told you already, and you have not listened, it will appear as if you are not paying attention. So here I'll just read a couple of examples. Patient says, oh, we have come to see you as my daughter Lucy is not eating and is losing weight. She is missing a lot of school and is tired all the time. I am worried. She is looking forward to her school trip, but I'm not sure if I should send her. So, when you say that, how can I help? The patients have said, the role player has said that, and then you say, what are your concerns? That will be a bad choice from the doctor's point of view or from your point of view, because they've already said that. So you could say, I can see you are worried. Do you have any idea as to what may be wrong that you may have discussed with your family member or noted on the internet? And then they may come out with options that you can explore further. So, history and summary station, specifically previous knowledge, presenting complaints, present gives details in their words, open questions, clarifications, acting on cues, show interest. Specific closed questions with yes and no answers, and then summarize and ask for further clarification before you finish. Finally, do not be locked in your thought plan and persist without acknowledging a response, because that would be disaster. You've already made up your mind what you think it means, and when you go in, you just carry on without taking note of what you have been told. So remember, role players, patients have a different agenda. You have to explore, identify, and address, and that is